First of all, it's such an honor for me to be standing in front of all of you here in Denver at the Academy meeting to present. I have been involved in dental sleep medicine since about 2010 and became boarded in 2013, and the journey's been an amazing one. And that just tells a little bit about myself. I'm a mountaineer, but I practice in Pittsburgh, Pennsylvania. I recently, at the age of 40, I'm saying I retired from general dentistry in October because I am so busy treating patients for sleep apnea. One little thing that's interesting in Pittsburgh is the fact that I participate in medical insurance plans along with 3 other gentlemen, some that are really well known, Dr. Rogers, Dr. Michael Nat, and we all participate in the medical insurance plans within the city. And what that has developed for us is such a collaboration, I feel like, with the physicians. I don't do any type of external marketing. What I've done is built the relationships with my physicians and with my sleep labs. The volume of patients that we see, I think, reflects upon the fact that patients are able to accept treatment more because they know that they're going to a provider that participates in their medical insurance plans, and therefore they're not going to have a lot of out-of-pocket expenses. So it's just what works well for us in our city. I think one of the most overwhelming and daunting tasks about when we start to decide to provide these appliances for our patients is where do we begin to know where to choose which appliance is going to work well for our patients. For me, I was really nervous whenever I started this, and I wanted to assure that I was doing the right thing for the patient. So I evolved and worked with some other companies. And I would have to say the thing that frustrated me the most is you would start working with a company, and you would get these great appliances, and I'm sure some of you guys have had this experience as well. And then you kind of move along, and things were going great, and then all of a sudden you get an appliance and it's rocking and it doesn't fit, and then you get another one and you start sending appliances back quite a bit, and then I pick up the phone and I go, listen to me, you're getting too busy and the quality's going down. What's going on? And so I'd give them another chance, and I'd work with them a little longer, and I'm like, that's it. And so this happened to me a few times, and I got kind of frustrated. So I think in 2012 we were at one of these meetings, and David and I had a long conversation, and I thought, all right, I'll give him a chance. So that's when our relationship started, and it's been a wonderful one. I think the key to our success, and maybe you can agree, is we communicate quite a bit. So it's either I'm sending him a text or I'm picking up the phone, but I also feel that this has really benefited us for our patient outcomes. And what I'm going to show you a little bit later is just 2 small cases that we've done recently where coordination of care between me and the lab, I think, has really helped with the patient outcome. So I'm sure that there's a lot of you in the room, just like me, who are treating a lot of patients with sleep disordered breathing, and we face so many challenges. One of the biggest challenges I used to have was appliances breaking, and then sending these back to the lab, getting repairs, remakes, things of that nature. And remember, I participate in their insurance plan, so it's not like I can charge the patient over and over again within the few years that they've received their appliance. So this was not just costing me a lot on my time and back end, but also for the patient. And it goes down the list. You have the patients who have a lot of acid reflux over their life. They get a lot of washout of enamel. Our enlarged tongues, how many huge tongues do we see every day? And what are we going to do for those patients? A challenge I had in the past was the bulk of the appliances. And I felt like the designs were counterproductive to what we were trying to achieve. So you would put this appliance in their mouth, and then they felt trapped, or they felt like their tongue couldn't come forward. And this led to, I felt, far more protrusion and much more TMJ pain. How about the patient that comes in with mandibular tori? What are you going to do there? They're in a panic already because they're anxious about their experiences in the dental practice. It's torture for them to get x-rays, and they're concerned that they're not going to really be able to wear anything in their mouth comfortably that's not going to rub on the tori and create problems for them. And then lastly, our patients who have beautiful crowns, veneers, and anterior work are very nervous about putting anything on those teeth and concerned about whether it's going to chip and break. So comes in my favorite, the Respire Pink. So the reasons why I loved when we transitioned to this appliance and I started working with David was the fact that what I found was that because of the nice balance all the way around the appliance, that the TMJ soreness was resolved. We could change our design when we had people who had anterior porcelain crowns and veneers, and we could eliminate the acrylic on those front teeth and still remain with retention. I was really concerned about the Herbstarns. This was a fear of mine. I thought they looked kind of gothic, and I was worried about what my patients would say. The thing I worried about was that going to rub on the cheek and cause a lot of soreness? And what I found in, I don't know how many hundreds of appliances we've done, but I've had under 10 patients complain of that symptom. And it's really nice to have a little plastic cap you just snap onto the screw and put it in the patient's mouth, and the patient goes, oh, that feels better. So it's a small little resolution. Another option too is the micro arms, and that works really well for our patients who have a really small mouth, and those are very comfortable for the patient and they do really well with them. But one of my favorite parts of this appliance is what I call the mini chin strap of the oral appliance. And with the ball clasps, you're able to put a little orthodontic rubber band there for our mouth breathers, and it keeps them closed, and it works great. Far better, I think, far more comfortable than a true chin strap. There's a lot of people out there, a lot of my colleagues who love a dorsal fin design. My personal preference is the Herbst, but I think that this is another great alternative, just like Dr. Takachi was describing, for patients as well. So about a year ago that you guys came up with the endurance framework design. When David told me about this, I could not have been more excited. I had the honor of being one of the first doctors to provide this appliance for my patients. And what we experienced was nothing more than outstanding results. What this resolved for us was, first of all, you have your patients who presented to you and said, I break crowns a lot, I know I clench and grind, I go through a night guard per year, I break everything. They belong in a Respire eval. They appreciated how strong and durable the appliance was. For my patients that had a significant gag reflex, the minute that they came to me, they didn't think that they would be able to wear any type of oral appliance in their mouth because of how bad their gag reflex was. Now I had the ability to do an appliance that didn't do anything to set off that response. That was really nice. The patients that have the anterior veneers and crowns love the fact that there is nothing on the teeth other than a little bit on the incisal edge. And if you can tell, the chrome is so thin, people instantly noticed that they had room for their tongue. So when we had patients who were transitioning from other appliance designs, and they were due for a new appliance, and I put them in this appliance, they instantly noticed, wow, my tongue has so much more room. And what I've experienced in my practice, and I don't know if anybody else has had the same experience, is that I found that the amount of protrusion just seems to be less for these patients than it is with the traditional style acrylic appliances. So I really like it. So this was just an appliance that I was going to insert on Tuesday. And the reason why I took these pictures was they've even honed down the design even more. So what you can see is that the only place that the chrome design is touching is on the teeth. There is nothing on the gingiva whatsoever. And it's amazing to me how beautifully well these appliances are designed, and that there's no rubbing on the gum tissue, there's no soreness, there's no adjusting like you would, you think you see chrome and acrylic and you're going to adjust it like you would a partial denture, and that just isn't the case. Here's the inside from a lingual view, and you see how on the lower anteriors, all that's touching is on the teeth. And then in the posterior, they do such a nice job of giving us ball clasps and rot wires so that we can adjust the level of retention on that appliance, and that works really well. Another side note, as you're seeing these patients on a yearly visit, that's the other beauty of these appliances, is the fact that instead of another type of style or company that provides appliances where you would lose retention and you'd think, oh great, I got to send it to the lab, I got to take new impressions, you know, you got to take I hate taking any type of appliance away from a patient. All I have to do is I take my lab knife or I take my pliers and I give the ball clasps and the rot wires a little tweak, boom, they're tight again, they're good to go for another year. The patient really appreciates that. This is just another view of that as well. So this is a patient that I had to take care of, and this is an intraoral view. And what worked really well for this patient is he had a huge tongue, he had a little bit of mandibular tori, but he was also a mouth breather. So what I do in my practice is I will start the patient out with the rubber bands, and I'll have them do the maxillary ball clasp just down to the mandibular screw. And I'll say, and if that's not enough, take it from the maxillary ball clasp to the mandibular ball clasp if you need a little bit more retention in order to keep your mouth closed. The patients that are mouth breathers really appreciate this, and they do really well with it. And this is him at closure. I know his vertical looked a little open there, and that's just what we were mentioning before. He needed more vertical height. I feel that between the vertical height and with using the EF framework, he had to protrude less, based on, you know, my predictions. So, who are our EF candidates? Well, what are you going to do with this tongue? It's huge. It's out there. There's nowhere for it to go. It has scalloped edges, and this was just at rest. So, when I see this size tongue, they're going in an EF framework. How about our mandibular tori patients? Not only do we have the tori to contend with, but also when we have significant tori, I feel it shortens the clinical crowns and it makes it more difficult to provide retention in those areas. And when you have the design of the EF that has all the nice clasps and extra means of retention, you can do this so well. These patients really appreciate the comfort of this appliance. And the other nice thing is we're getting their tongue up and over and away from that tori where the tongue is supposed to be. How about your patients who have been mouth breathing their entire life, the bilateral posterior crossbite? So this is what they look like when you first look at them, and then you look at their palates. This patient, I couldn't even stick my finger in their palate. That's how narrow they were. Ordinarily, in the past, I would say, what on earth am I going to put in their mouth that they can actually wear? There's just no room. And now I don't even hesitate with that type of patient because I know we'll be able to achieve a successful outcome with the endurance framework because it's not going to encroach upon their palate, it's not going to encroach upon their tongue space, and we're going to be able to provide relief for the patient. So this is just one of my patients. And, you know, at a first glance, she doesn't look too narrow, but a little bit. You see her buccal corridors are a little bit dark. So this is what you see intraorally. On the maxillary, she was a product of, she didn't have 4 premolar extractions, but she had 2 on the top. So in turn, what that did was pulled back her premaxilla. And then over time, the mandible had no room whatsoever. So she had a lot of crowding over the years, a lot of clenching, which led to a lot of the mandibular tori that you see. And guess what? On top of that, she has a significant gag reflex. So I had limited space, mandibular tori, large tongue, significant gag reflex, and she said, I'm really worried. I mean, I'm here. I'm just really doubtful I'm going to be able to wear anything inside of my mouth. I know how hard it is for me to even have a hygiene visit done. I don't know how well that's going to work out for me. So we made her an endurance framework appliance, and she was able to close, and she's doing great. She's in the process of getting a follow-up sleep study, but subjectively, she's able to wear it all night. She's no longer snoring. Her morning migraines and headaches have improved. and I think we're gonna have a positive result. This is just another interesting clinical case, and this is just driving home my point about collaboration and communication. So when you look at her, she's a beautiful woman. She has beautiful teeth. What's really interesting about this patient is that she has full maxillary mandibular fixed implant retained bridges that were completed in Costa Rica. So she flew, and when she told me this process, I couldn't get over it. She flew to Costa Rica twice and had all the restorations done, because it was a big investment. And she saved a little bit of, well, I guess a little more than a little bit of money to go to Costa Rica, but okay. Well, then we took a look inside her mouth. The one thing that was notable to me when I was doing her patient interview was she continued to lisp. And I kind of asked her about that, and she said, this is a problem that resulted after I had the work completed. And I said, okay. So take a look inside. Maxillary looks pretty good. A little bit narrow, right? I don't know if you can appreciate this, but the implants were placed lingually on the ridge. So as a result, the mandibular fixed restorations are all lingual, and she literally had nowhere for her tongue to go. And I thought, what am I going to put in this patient's mouth? A, she has severe OSA. B, she has significant DSATs. C, she's tried every CPAP product out there. I mean, she's given it the old college try for a couple years. And she has very mild COPD. So, she's in my chair. So what we did, David and I decided upon, we actually did a regular Respire Pink. But obviously my biggest concern was I didn't want to do anything to create stress on the implants or the bridges. And I wanted something nice and soft. So we did a soft internal acrylic liner. We did a Respire Pink, and she is transitioning very well in that as well. So in summary, I just think that now that we have the advent of these chrome appliances, this is just another tool for us to use in our patients that provide challenges for us, that have some extraordinary needs that we need to address. I feel very fortunate to be able to work with David and Whole U and the whole team over here. And I want to thank everybody for allowing me to talk.